Thank you for being in attendance today. My name's Angela Crack. I'm from the University of Portsmouth and I'm chairing this session. Before we go any further and I introduce our guests, may I ask for a volunteer to be rapporteur for this session, which requires noting down the key points, the big picture messages that come from the panel, reflections on trends in the field and challenges and gaps, recommendations, particularly recommendations that are relevant to the Sustainable Development Goals. If you make a note of these main messages, they'll be fed back down to the session in the end. So could we have a volunteer to fill out this form? Anyone feeling generous today? We have someone over there. Thank you very much. Thank you very much, sir. Okay, so we shall get started without any further delay because we're running late, as have the other programs, the other panels before us. And I know that you'll be wanting to go to the plenary at 5, so we're going to keep very strictly to the following timetable. Each of our presenters are going to be given 20 minutes each, and then the remaining time will be spent on question and answer. And let me, without further ado, introduce who our presenters are. First of all, we have Laurie Thicke, who is the founder of Translators Without Borders, a Canadian living in Paris, who is presenting the paper to us today called The Opportunity of Digital for Local Language Accessibility in Health, Citizen Rights, Environmental Protection and Crisis Relief. And we will then go to Chinyere Mbaka, who's a doctoral student in the University of Ibadan, and her focus is health communication. Her paper is titled The Language Challenge of Diabetes Information and Education in Nigeria's Multilingual Setting. So first of all, Laurie, thank you very much.
Thank you. I'm going to stand up. I'm going to stand up because I'm so excited. I don't want to sit down. You know that languages is important. That's why it's so great to be here today. Normally I speak for 40 minutes, but I have to spend the first 20 minutes explaining why language matters. So with you I can save those 20 minutes and just go into my presentation. My whole adult life has been spent in languages. Both my professional life as the founder of Lexcelera, a translation company based in Paris, and my volunteer life as the founder of Translators Without Borders. Today I'm going to talk about bridging what I like to call the language last mile. We hear a lot about the digital last mile. That's the distance between the knowledge that people need to live healthy and prosperous lives and the homes and hands of the people themselves. Well, now with technology, we've virtually bridged the digital last mile. So it's time to talk about the language last mile. And to do that, I'm going to talk about some of the projects that Translators Without Borders carries out. First of all, let me tell you the history of Translators Without Borders. It started in 1993 when Médecins Sans Frontières, or Doctors Without Borders, asked my translation company for a quote for a project. They wanted to know how much we were going to charge them. Well, I've spent my whole life meaning to volunteer, but I was just always too busy, so I thought this would be a good opportunity. And so I said to them, if we don't charge you for this, can you use the money in the field? And they said yes, they could, and Translators Without Borders was born. That was in 1993. And in 2010, with the earthquake in Haiti, everything changed. It's funny to look at it now, and I'm ashamed to admit it, but until then, we weren't really aware of local languages. We were doing a lot of work in European languages, helping nonprofits communicate with their donors, to raise awareness when there was a crisis somewhere in the world, but we were mostly working in European languages. In Haiti, we saw that when information was aid, it needed to be in the language of the people spoke. It also needed to be in real time. So the two lessons from Haiti is that Translators Without Borders needed to change. It needed to scale up, needed to ramp up using technology, and it also needed to respond to people's needs for information in their own language. Today, Translators Without Borders is the world's largest humanitarian translation organization. Since that day in 2010, when Translators Without Borders changed, we've translated 50 million words for nonprofits. We have about 500 nonprofits that we support with the help of around 20,000 language volunteers. Translators Without Borders is also building very strong partnerships, like with the United Nations, with Oxfam, the Red Cross, and refreshment societies to deal with crisis relief. So the main areas today are crisis response, development and preparedness, capacity building, and advocacy.
I'm Chinyere Mbaka from the University of Nigeria, also from Ibadan, Nigeria. I'm a doctoral student, and what I'm about to present is part of the result of my doctoral thesis. I think if there is anything we have agreed on since we started this conference is the fact that language is very, very important in development. And looking at Nigeria, the challenge of diabetes information and education in Nigeria's multilingual setting. Nigeria is different from so many other countries you know because of the many languages that we speak in that very country. We have about 500 or even more languages. And for development to really be effective, you must talk to the people in the language they will understand. So the challenge here is I'm focusing on health communication disease. The challenge here is Nigeria being a multilingual nation. How do you use a look to diabetes education? Introduction, I already said most of the things that can be prevented. Now, where I am bringing this to a language conference is the fact that knowledge has been said to be key to diabetes self-management. Now, how can you pass knowledge without passing it through the medium of language? Then if you're passing it through the medium of language and you're using the language that is not mutually understandable, that is not accepted, a language that is not inclusive, then the effects you are looking for, you may not get. So the problem is, since knowledge has been identified as a very powerful asset in the fight against diabetes, it helps people to assess their risk level. It motivates them to seek for and adhere to proper treatment and care. It inspires them to be in control of the disease throughout their lifetime. Again, the kind of knowledge that we talk about here can only be gotten through information and education given in a language that is mutually intelligible and culturally acceptable to the audience. Then, how can you do that effectively in a setting such as Nigeria? Because of what I've already said before, the multilingual nature of the country. Now I have some study objectives that guided the study. The first one is to determine the extent the local languages were used for diabetes education in Nigeria, the urban centers and the semi-urban centers. I didn't look at the rural because most times that's what we get in the rural areas. We have local language used in diabetes education. So I'm looking at Lagos and Ogun State. They are the semi-urban areas and urban areas of Nigeria. Number 2, to establish the knowledge level about diabetes and its management among study participants. And number 3 objective is to determine the extent the local language use, for diabetes education can influence improved diabetes knowledge and then lead to effective self-management and prevention. The methodology is purely a qualitative study. We use focus group discussion, interviews, and personal observation of the diabetes education sessions. The data, of course, we are coded and analyzed using thematic explanation. Then the study location, like I said, is Nigeria. I used 2 states, Ogun State and Lagos State. 2 teaching hospitals, tertiary institutions. The first one is OOUTH and the second one is LASUH. The OO is in Ogun State and the LASUTH, is in Lagos. Okay, the focus was on the diabetes patients, people living with diabetes, PLWD, the diabetes educators, and then the medical personnel, doctors and nurses. The sample size was 40 persons per center. Since I used 3 centers, 40 times 3, 120, and then 3 health personnel, 1 from each center. Then to the findings. For the objective 1, which is to determine the extent the indigenous languages are used for diabetes education in Nigerian urban and semi-urban centers, we found out that the indigenous languages are rarely used for diabetes education. In Lagos, in Ogun State, most times what they use is the English language to pass across this diabetes education to the diabetes patients. Reasons being that from the interviews we conducted with the medical personnel, they said Nigeria is a multilingual nation, and if I teach in Yoruba, the Igbos will complain, the Jaws will complain. So what do you want me to do? Okay? So they adduced reasons such as a heterogeneous audience made up of people from different ethnic groups and language, speaking different languages. Then again, they said Lagos and Ogun State are semi and urban areas. So mostly people you find there will be people that are enlightened, people that can speak and understand English language. And then another thing which is very key to this study is the fact that there were no IEC materials, that's information, education and communication materials. They are not available in the local languages. Most of these materials are available in English. And in Talabi, which is the third center, we discovered that that is the only place. And reason being that that is a very rural area of Ogun State. You know, I told you I used 2 states, Ogun State and Lagos State. So that TDC is a rural area, and that is the only place they used. You have diabetes educators teaching in the English, in the local language, which is Yoruba. Now for objective 2, which is to establish the knowledge level about diabetes and its management among study participants, we discovered that in those 2 centers where English was the dominant language of education by the diabetes educators, we found low level of diabetes knowledge among the study participants. Most of the diabetes indices, complications of diabetes, signs and symptoms of diabetes, how to manage diabetes, the questions posed, they were not able to answer them. Now, various misconceptions also were found about diabetes. Many misinformations also were given by the study population. Now, from the focus group discussions, we discovered that these misconceptions and misinformation were because of the difference in the language of education and the language of the local language being spoken in the vicinity, in the community. For instance, the 3 major tribes in Nigeria are Igbo, Hausa, and Yoruba. And if you look at their word for diabetes, it simply connotes blood disease. For instance, in Igbo language, they have Oria sugar. Yoruba will say Eto sugar. So sugar is always represented. But if you look at what diabetes is, it's not actually sugar as in sugar that we know. It has to do with a lot of things which were misrepresented using the foreign language to teach or English language to teach. Now, findings also that has to do with Objective 3. The Objective 3 is to determine the extent the indigenous language used for diabetes education can influence improved diabetes knowledge and positive attitude to diabetes self-management practices among people living with diabetes. Now, we found out that better understanding of diabetes self-management activities, especially food types, were observed. And this is very important because we observed that in the TDC, which is the rural area. We also observed that in Lagos. A feeling of exclusion, which is the challenge that I'm trying to bring out here. Very, very interesting when we discovered that. Now, in Ogun State, the local language there is Yoruba language. Now, in Lagos, he said it's more of a metropolitan city, so you have people from diverse ethnic groups in that particular state. Now, when they come for these diabetes clinics, the diabetes educators will teach them different things they need to know about diabetes and then ask them questions before the doctors come to attend to them. And you find out that you have people from different ethnic groups in that setting. Now, teaching them in English will kind of, alienate those that really don't understand English. Then if you choose to teach in Yoruba because you want to use the local language, you find out that you alienate, you exclude people that don't understand Yoruba. So that is a problem that we have found in this study, is a challenge. So a feeling of exclusion and disenchantment was found among participants from other indigenous language groups. And that was a big issue that we discovered. Because at a point during the focus group discussion, it was people were complaining. They are only after Yorubas. They don't want to teach Igbo. So something almost degenerated into an ethnic war, ethnic disagreement. And it's very important I take note of that. Now, most participants preferred diabetes education sessions in their native tongues and are more willing to accept and adopt self-management activities explained to them in their native tongues. Now, despite the fact that people were feeling the ethnic angle came in, also people felt motivated, they felt persuaded when people that are using their own local languages talk to them. They feel, this is my person, he can't deceive me. This one is speaking to me in my own language, I think I understand better. So these two angles, exclusion of people that don't really use the native language of education at that particular point in time, and then the joy of having someone speak to you in your own language. So it was like a crossroad that I have gotten to. And then the general findings: diabetes education is a challenging activity. That's where what we realized at the end of the day is a challenging activity in Nigeria because of this multilingual nature of the country. English language sessions are flawed by lack of clarity in explaining some concepts and conditions in diabetes and diabetes management. Then local language sessions run the risk of causing divisions among the many tribes that are present. You may find out that you are arousing ethnic sentiments and tensions among your audience. Then majority of the diabetes educators interviewed preferred using the English language for reason of ease, availability of the teaching materials, IEC materials, and then to avoid generating ethnic sentiments or bias. Conclusion: Nigeria is a multilingual nation and diabetes education have been found to be provided in English language in majority of the settings we visited, but this hampers effectiveness of the diabetes education, engendering positive health outcome. But in order to avoid this, you made some recommendations. I will still come back to the questions. You make some recommendations. There is need for IEC materials to be produced in the local languages. And I would also like us to, maybe by the time we start asking questions, because the essence of bringing this, I told you that this is my part of my doctoral work. So the essence of bringing it here is to answer the questions that I posed in the second to the last slide. Let me be through with this first. There is need for the IEC materials to be produced in the local languages to assist the diabetes educators. Interpreters, translators should be employed and trained in the major ethnic languages to assist diabetes educators at the session. Okay, and then there should be a profiling of the PLWD, people living with diabetes, in every center. And then their language of education and other preferences should be taken and arrangements made to meet them in the interest of inclusiveness. Now, how that is going to be possible, I may not know. But because in a center you may have up to 20 to 25 different languages. So are we going to have translators for 20 languages while you speak in maybe English or something? I don't know. Okay, then the question is that the only way? That's what I asked before. Are there other ways? Are there other ways? Educators see it as the only way to avoid some of the identified challenges. That is, they see teaching diabetes education in English language as the only way. So my question to the House this afternoon is, are there other ways that one can tackle this problem of multilingual problem of Nigerian nation, teaching diabetes education using the local language? Is there any other way? Must we teach in English? Or are we left with the only option of translating to many, all the languages in Nigeria before we can really have an effective diabetes education? Thank you very much.
Unfortunately, we have such little time for questions. If it's concise and get straight to the point, so we can allow the most time possible for our presenters to elaborate on their findings. I have been asked to allow the presenters to answer one question at a time rather than collecting a round of questions. So we'll just have bilateral questions, if that's okay. Anyone to volunteer? Okay, thank you.
I'll be very quick. Thank you both for really interesting presentations. I have a question for Lori, and realizing that Translators Without Borders, this is work that's not for pay. I had a question about the people who are candidates to become translators, how they're vetted for their competence, and then how the accuracy of their translation is monitored once they undertake their work.
Okay, for sure. They're vetted, first of all, that they've worked for 2 years already, and then they have to submit a test. Monitoring their quality is done more in the tools than physically, because a lot of the work has to be turned around very, very quickly. So it's a question of vetting them upstream rather than downstream.
The healthcare provided local people. Language or vernacular, whatever it is. Then the advantage is but it also allows more attention on the part of the advisee, the person of the patient. Why are we in a situation where the healthcare provider would need an interpreter to communicate with the patient?
Taken by many people. And this setting that we use for this study is the location is a semi-urban center. Lagos is an urban center, and then Ogun State is a semi-urban. And there you find people from different ethnic groups who speak different languages. So the healthcare provider or the diabetes educator in this context may be able to speak only one local language. And we have people speaking about 5, 10, 20 local languages at that point in time. So what does he do? How does he get across to them in their local languages? Would he have to use the option of English at the end of the day? Or choose one local language at the expense of, at the risk of inciting ethnic sentiments, ethnic aggressions and all that? So that is the predicament we face.
May I ask a follow-up question? Why doesn't this kind of the market where people from different backgrounds come in contact with each other and they trade goods and they don't need an interpreter, and when it comes to healthcare the problem arises? Or is it because there aren't enough healthcare providers in the first place? Because if there were many more healthcare providers from different ethnic backgrounds, then the problem may become an artificial one.
Well, I think again, we are talking about education and not just market setting. Yeah, somebody just goes to buy something, you're not educating anybody there. But in diabetes, for the diabetes situation that you painted, you have a classroom or a hospital setting with people there and you are the teacher. So you have to teach me and I have to learn. But in market setting, you just go and buy. So even if it's one word you know how much, then that is what you say and you buy what you are buying. You don't need anybody to educate you on that particular, on any other thing, or just to buy, to be able to communicate to the extent that you make your purchase and leave. So I think that's where the problem is coming from.
Referring to the lack of, we don't have enough healthcare providers. So if we had enough healthcare providers who spoke all those languages, I think the issue of not understanding will not arise. So how do we manage to get more healthcare providers in such urban settings where so many people speak different languages?
How do we manage?
To have enough healthcare providers that speak all those languages, to be able to communicate with all those people speaking all those languages. So I think that's also an issue.
That is the problem that I raised. If you have 20 languages, people speaking 20 languages in that particular classroom, then it means you have 20 diabetes educators or 20 translators or interpreters. And that's the problem, that's the challenge. I'm asking the question you're asking, so what do we do?
Yeah, what do we do? So.
Yes, I think it's important for us to understand the situation of Nigeria. Nigeria has about 265 languages. And the question is, are you going to get somebody, a healthcare provider, in all this, 550 something languages? That is the point. So that is what the challenge is. How do you manage it? Cameroon has 285 languages. How do you go about it? Thank you.
For me. But one of the things that Translators, because it's a really good question, and one of the things that Translators Without Borders has been studying is, so how many languages does it take to get 85% of the population covered? And I think maybe that's a more reasonable question for now. What are the main regional languages, the biggest tribal languages that we can cover, and then at least we can say in a clear conscience, we've got the majority, but today we're not getting the majority, and I think that's what your really interesting study is saying. Excuse me for giving my...
Actually, you can get diabetes educators, to translate for the major Nigerian languages, which is Yoruba, Hausa, and Igbo. But we are talking about inclusiveness here. So by the time you teach me, I'm a minority, I speak a minority language. So you teach me in either of the majority languages, then you have excluded me at the end of the day, because you're not teaching me in my own language. So if you choose to teach me in Hausa and I'm a job, for instance, then it means you don't have regard for me as a person, and then you have excluded me from the whole process. So I'm not looking at a situation where we have just the major languages having translators or having diabetes educators, but all the languages, or as many as, let's say half the languages, if it's possible. I think Nigeria has about 500 languages, so if you can have 250 diabetes educators, speaking 250 languages in Nigeria, I think that would be a long way, but that would be a tall order too.
Au fait, ce n'est pas une question, c'est justement pour abonder dans le même sens, pour dire que le premier intervenant ça va? Donc je disais, le premier intervenant a montré les avantages lorsque, en plus de la langue ou de la traduction,
actually the conversation has been on media strategies that these diabetes educators use for diabetes education. And I know videos, audios, flyers, all these things have been explored. But even if you want to use video, won't you use it in all the languages that you want to that you have participants in? So you still need those languages. I'm not talking about the device or the technology, but the language, having people that can translate those languages for the understanding of the diabetes, people living with diabetes. So it's not just video, but the video has to be translated in all the languages of those present. So videos have been used, but mostly Yoruba, Hausa, Igbo, and maybe few minority languages. Yes, it's possible, but is it possible for us to have videos in Ishekiri and in all the languages of Nigeria? Or as I insisted before, maybe half of the languages of Nigeria? I'm not sure. And if anybody has a better suggestion, I will also like to, because that is the essence of this presentation. That's the challenge we have. That's why I brought it here, so that people can give me suggestions on what to do next.
Ici, je donne un exemple dans une salle de classe. Un enseignant qui se trouve en face des enfants, qui certains sont de la zone linguistique, c'est-à-dire qui parlent la langue du milieu, et les autres, par exemple 2 ou 3 enfants, qui viennent d'une autre zone linguistique. Le grand problème, comme on venait de le dire avec la première présentatrice, vous avez les images, les illustrations, auxquels on peut pouvoir accompagner des explications. Or, ici, le problème qui se pose, c'est un problème tel que la communication ne se fait pas seulement par ce que l'autre attend. Les gestes peuvent aussi amener à celui qui est là de bien comprendre. Un exemple totalement simple. Vous arrivez à un milieu, vous trouvez quelqu'un qui est en train de pleurer. Est-il vraiment difficile de comprendre que cette personne pleure? Donc, le problème est tel qu'il faut une très bonne didactique à enseigner et deuxièmement de savoir quelles sont les personnes qu'il faut pouvoir affecter pour réaliser ce genre de travail. Et ces personnes-là doivent être formées, comme on l'a dit tout à l'heure. Ils doivent être formés, ils doivent être des outils bien adaptés par rapport au contexte, de telle sorte que le message puisse passer, qu'on soit en mesure d'atteindre au moins le public cible. Ça, au moins, une proposition. Parce que nous avons l'expérience dans nos salles de classe où les enseignants posaient pratiquement le même genre de questions. Mais après l'étude, on a constaté qu'il est possible que les enfants venant d'une autre zone linguistique avec une bonne volonté de comprendre le message à travers les illustrations, les images qui sont accompagnées de messages qui sont en fait libellés dans des langues de ces patients-là, s'il faut le dire. Le message peut bien passer, ils peuvent bien comprendre sans difficulté. Donc il y a un problème d'information à travers le message qui accompagne les illustrations ou les images. Voilà d'une façon brève ce que je peux dire.
That there is need for IEC, information and education and communication materials to aid to go a long way towards passing across these messages. So that even if you couldn't get people to translate, people that speak all those various languages, at least the materials they prefer, the teaching aid can go a long way. So I think that's one thing I'm taking away. That's very important.